Hi students, I hope you can all hear me well. I'm just trying to check if things are working on my side. I'll just check on the phone. Yeah, yeah, we are working. Right then, good evening everybody and welcome to these deliberations once again. I hope you can hear me well. And today we are going to talk about fetal surveillance. Now, when we talk about fetal surveillance, it is that one topic which you have to understand. It is the core of obstetrics. I don't know what all you have read in your medical colleges so far about the diseases in pregnancy. Like there's a normal pregnant woman, we have to be vigilant about her. But there is a woman who is probably having diabetes in pregnancy or hypertension in pregnancy, whatever is the reason. We've discussed that earlier. Now, whichever problem she is suffering with, then also we have to be vigilant. So, any woman who is coming to the OPD, we are vigilant about them. But when women are having high risk pregnancies, we have to be more vigilant. Let me try and tell you in a different way. If I ask you what is the drug of choice for hypertension in pregnancy, you'll tell me it is labetalol. What is the drug of choice for diabetes in pregnancy? You'll tell me it is insulin. Yes, fine, you're correct. But so far, you know the pharmacology of this condition. But to diagnose that this woman has diabetes, let's say she is a woman who is having diabetes and she is 26 weeks of pregnancy. Now, with the high sugars, we know the biggest problem which can happen is that the baby can die intrauterine. So now we have to continue the pregnancy keeping the mother's sugars in control. And with the high sugars, the baby which can have an intrauterine death, that baby should be doing fine. So we have to keep on vigilance for the mother definitely, but for the fetus also. So the tools of surveillance will help me in my vigilance. So this woman has diabetes, I have to control her sugars and make sure the baby is fine. So I do tests of the movements of the baby. I see if the baby is moving and his heart rate is increasing with the movement or not. I see the Doppler of the blood vessels to see if the blood supply going to the baby is good enough or not. With that, I buy 1 week. Phew. Now, next week again, I do the movement test. I see the fetal heart rate of the baby. I see the Doppler of the baby, or I see the Liker of the uterus, whether it is good enough or not. Then I buy 1 more week. Like that, I go on pushing this pregnancy with my vigilance, and I reach 37 weeks term. Thank God, I've reached 37 weeks. So, how do I reach 37 weeks? Is with this surveillance. This surveillance is what is obstetrics. To know surveillance is to be an obstetrician. Look, if you know the drug of choice, you know the pharmacology well. But to be an obstetrician, you have to know your surveillance. And if you know surveillance, then only you can make sure the pregnancies go till term. And then this surveillance has to be followed by more surveillance when the baby is delivering. When the woman is delivering the baby out, that time we have to have even more intensive surveillance, intrapartum surveillance. That is what is obstetrics. To know that there is a problem and continue the pregnancy keeping in accordance with the management of the baby and management of the pregnancy and keeping the health. So that is what is surveillance. So biggest topic of obstetrics, I'm telling you. After PPH, there is that one topic I kept telling in the exams when we are doing the preparations, that do not leave the house without reading about surveillance. And this recent NEET exam, INACT exam, and now the 17th of Jan, they had this MCI exam. Every exam, one question was there, or two questions were there on surveillance. So without surveillance, you don't know obstetrics. All right. So yes, with that introduction, let's get into the topic. So how you do the surveillance in pregnancy? So yes, the best method to take care of pregnant women is to do the surveillance. This is a picture of a ultrasound machine just to depict the surveillance. But yes, antepartum surveillance, which is before delivery, intrapartum during delivery, rather than after delivery. It should be during labor. All right, it should be during labor, and that is the surveillance you have to do during delivery. All right. So yes, antepartum surveillance. Antepartum surveillance, that during pregnancy, how you surveillance about a mother. So OPD visits. Any woman who is pregnant should be coming to the OPD. We are going to see every pregnant woman at least 4 times. Like we say in India, we say at least 4 times you should come to the OPD. So in India, we say at least 4 visits, and the first visit, one visit should be there in the first trimester, one visit. second trimester there should be 1 visit, and in the third trimester there should be 2 visits. Then the ideal number of visits is actually 12 to 14 visits split over the first, second and third trimester. Ideal number of visits. You have to see the chapter of antenatal care in the app to know the proper antenatal care. I'm just trying to say what is the basis of the surveillance. Then what is the WHO recommendation? Look, WHO recommendations, if they ask you WHO, then only you say. WHO recommendation says there should be at least 8 visits. So 8 visits, first trimester there should be 1 visit, second trimester there should be 2 visits, and the third trimester there should be 5 visits. So total 8 visits WHO feels that you should have. But yes, that is what is the norm of any pregnant woman. But suppose there is a high risk pregnancy, like there's a intrauterine growth restriction, gestation diabetes mellitus, hypertension, and antiphospholipid antibody syndrome, anything, multiple pregnancies, oligohydramnios, all these high risk pregnancies, we have more chance of losing the baby. So then you increase the surveillance even more. So high risk pregnancies, like you can as and when required. So you will have to call this woman to the OPD, the medial 2/3 and the lateral 1/3 in the spino-umbilical line. That's where you put the stethoscope and you get the fetal heart rate in the classical left occipitotransverse position. So stethoscope, you'll see the fetal heart rate. Fetal Doppler, you can see the fetal heart rate. This is the Doppler machine. These are mostly those Chinese products. The market is full of them, these portable Dopplers, very cheap in fact. And with this, you can, in the OPD, you can listen to the fetal heart rate as a doctor, and the mother also gets very satisfied that the baby's heart is nice and loud. And then the Pinard fetoscope. Now, this is the traditional instrument which we all use. Pinard's fetoscope, some of us who are traditional obstetricians, like I love to call myself, we will use this instrument. It's a conical instrument made out of aluminium. Steel is also there. In fact, in the cold countries, they use wooden Pinard fetoscopes, and doctor, and the conical part goes into the metal abdomen. See, this is how it is done. This is the Pinard fetoscope which is used. Then this is how you see the fetal heart rate. Then what about the basis of the fetal heart rate? Now, what is the normal heart rate and what is the acceleration and what is the deceleration? A normal fetal heart rate, if you see, the normal fetal heart rate is something like to 160. Now, the heart rate can be 130, 140, 150. Between this, it is supposed to be normal. Now, try and understand this part of the class. It's extremely important. If you see the heart rate of a baby is between 120 to 160, the perfusion is going on fine. But keeping in this range, the heart rate may suddenly increase. So that heart rate has to be a significant increase to be called an acceleration. Suppose the heart rate is something like 130 and it increases to 135. That's not an acceleration. It has to increase at least 15 beats to be called an acceleration. So heart rate is 130, it increases to 155. It's a 25 rise, it's an acceleration. The heart rate is staying at 140, it becomes 160, acceleration. Similarly, what's the deceleration? Deceleration is the heart rate is suppose like 1 to 130, deceleration. It is 150, it comes down to 120, deceleration. So acceleration, deceleration is between 120 to 160. Mind this, listen to this, rewind and listen if you're seeing this a recorded lecture. Acceleration and deceleration is between 120 to the baseline. Suppose the baseline is 130 and it increases more than 15 beats, it's an acceleration. What is the deceleration? Reduction in fetal heart rate by more than 15 beats per minute from baseline again. So that should be between 120 to 160. It should not go less than 110, because less than 110, this, and more than 160, that is known as distress. So this is what you have to know. I'm so sorry, but my intern friends and my first EPGs, after reading a lot and passing a lot of exams, people get these definitions a little blurred, and that can cause disasters in the labor room. Be very careful, guys. Between 120 to 160 is normal. Up to 110 also we are happy. Less than 110 is distress. WHO says less than 100 is distress. That definition variation is there, but less than 110 we say it is distress. So do not confuse deceleration with distress. first major point of this topic. Okay, so increase in fetal heart rate by 15 or decrease in fetal heart rate by 15 or more, say by around 9, and at 9 o'clock she starts counting the movements, and by what time she gets 10 movements, that is what is taken. So generally around 28 weeks and beyond we do it, and it takes assess the time to feel 10 movements, and the average time it takes is something like 2.7 hours to get 10 movements. So basically, even if it takes longer, we say the baby is fine, but I'm just saying average it takes 2.7 hours. If it takes longer, that doesn't mean the baby is not very healthy. It's just that this baby is sleeping more than the other babies. That's all. So that doesn't matter. Now, the similar assessment of movement can be done by the Sadowski's method. So Cardiff's method is how long does it take to get 10 movements? Sadowski says don't go by that. Just after every meal, count the number of movements. We tell the mother that if you're having breakfast, lunch and dinner, 1 hour after that, you count the movements, because food will increase the sugars, and the sugars will go to the baby, and the baby gets sugars, he'll start moving in the tummy. So the number of movements after a meal, will give us indication that the baby is healthy enough. So yes, Sadowski's method is count the movements after all major meals, after 1 hour of all major meals. So then again, if there are more than 10 movements in the waking hours, the time when the woman is awake, in the waking hours, if there are more than 10 movements, again it is a healthy baby. Yes. So before I go ahead, let me see what are you guys asking me. Network issue, when FHS can be heard first time. When can the FHS be heard for the first time? Yes, it's a related question. I'll not ignore that. So we're talking about the fetal movements right now, and I should have seen the question before. So fetal heart rate by transvaginal sonography, you can see in the 5 weeks plus 3 days, which is basically the 6th week. And by the Doppler, you can see by 12th week, and by the stethoscope you can see by 24 week onwards. Stethoscope or the pinard fetoscope roughly by 24th week onwards. All right, a lot of people claim that I can hear the fetal heart rate even by 18 weeks by the stethoscope. God bless them, they must be having very sharp ears, but we are not talking about the nerds. We are talking about the people who are normal like you and me, and stethoscope 24th week onwards. All right, so we were talking about the antepartum fetal surveillance. We spoke about the movements. Before that, we spoke about the fetal heart rate. Now, the biggest test in the antepartum fetal surveillance is the non-stress test. So before we read about it, let me tell you that when you move, like you're now sitting and taking notes, and your heart rate must be around 70. When you run, your heart rate will go up to 100, and then you come back and rest, and you're not doing anything great now, and you're just sitting and taking notes. You're physically not very active, just you're moving your hand to take notes, that's all. So then your bodily activity will reduce, your vagal tone will settle, and once the vagal tone sets in, your heart rate will go back to 70 again. So when we move, our heart rate increases. When we sit, our heart rate reduces. Similarly, when the baby moves in the tummy of the mummy, right? When the baby moves in the tummy of the mother, the movements will increase the fetal heart rate. So that is what is the estimation of the fetal nervous system, the sympathetic and the parasympathetic nervous system. The autonomic nervous system is set by 28 weeks. So every time the baby moves, the heart rate should increase. And if the baby moves and heart rate increases, we feel the baby is healthy. So that's what is done here. Look here, the mother is lying down in the OPD with the belt around her tummy, and that we have put a Doppler probe, and the Doppler probe is marking the heart rate here somewhere in a graph like this. And every time the baby moves, when the baby moves, there's a movement marked here. So with the movement, we expect the heart rate to increase. So that is what is done by the probe in the mother's hand. The other, there's a button she presses. So there is one probe on the abdomen. This is the non-stress test. You know what they ask you in the exam sometimes? What test is going on? And you should know that if it is one probe, it is the non-stress test. We're going to discuss intrapartum surveillance where there are two probes. One probe non-stress test, two probes is the cardiotocography. All right. So don't get confused by the number of probes. One probe, matlab it is NST. Non-stress test. देखो internship ना, internship you will muddle up NST and CTG. You will keep saying CTG for NST and NST for CTG, and that's where I get a little upset with interns, because once they read so well, immediately in internship everything is, everything gets blurred and everything is a big gray. That sharpness is lost during internship. Yes, you're working a lot. I know you're working a lot in internship, and yes, well done. You're the support for any department. Apart from helping us in the surgeries, you do a lot of paperwork also. Yes, we know that. But do not lose your sharpness of theory. The purpose of making you involved in paperwork, it is required for every doctor. Even now I write discharge summaries as the head of the department sometimes, because when my fellows write the discharge summaries improperly, I say, okay, let me write this properly. So there is no work that you should not do. You will become a surgeon, you will become a specialist, you will become the head of the department, or let's say of pathology or microbiology, but you should always know your paperwork, because that's what makes you a complete person. Okay, so you are never too small to do paperwork. Always remember that if you know your paperwork, then you can make sure your junior staff can do that work properly. So yes, interns, thank you for all the help you give us, but remember, keep your sharpness intact while you are working. So non-stress test is the assessment of fetal sympathetic and parasympathetic nervous system. So it is done generally after, it can be done after 28 weeks. We generally do after 32 weeks. Can be done theoretically. This maturity is achieved by 28 weeks, but we generally do around 32 weeks. So it couples the fetal neurological status to the cardiovascular reflex response. That baby moves, heart rate should increase. So it's an OBD procedure done after generally a meal. It's done after a meal because the sugars will increase. Position is a left or right lateral. You will not do in a supine position, because the supine position will cause the mother to have a supine hypertensive syndrome. The baby's weight will press on the vena cava and the mother's cardiac output will reduce and the baby will get hypoxic. So always do in a slight lateral tilt, left or the right lateral tilt. So that's how you do it. So what is the interpretation? Let me see if I can show you this video. Yeah, I'll try to show you this video. Yes, and then I'll start again. Yeah, see this video. So you see this, I've kept the volume down, so it's like a galloping horse, you'll hear the sound. So with the fetal movement, see, this is the movement which is marked here, the heart rate should increase. This is what is the normal graph of NST, and that is coming also on this, the machine which is there. Okay, so that's how with the movement you should see. So this heart rate increase with the fetal movement. With the fetal movement, there is increase in the heart rate, and then again with the movement there should be increase in heart rate. So how much increase is a good increase? Yes, again the definition which I told you. To say it is an increase, it should be at least a rise of 15 beats from the baseline. All right. So yes, the interpretation reactive NST is with the fetal movement, increasing the fetal heart rate by 15 beats per minute from the baseline, lasting for at least 15 seconds and occurring at least more than equal to 2 times in a 20-minute study. That is what is called a reactive NST. Now, before I go to that next part, please remember this definition. This is hot shot, okay? This is what is coming in all your theory exams. It is coming in the entrance exams and it is coming in your vivas. They'll ask you what's the reactive NST definition, because they'll put an NST in front of you, and at the MBBS level, we don't expect you to tell us all the abnormal type of NSTs, but at least you should be able to tell me the normal NST. And normal NST means with the movement, increase by 15 beats, lasting for 15 seconds, occurring at least twice in a 20-minute observation time. So this is what is a reactive NST. So let's go back. I just want to show you this. See, there are two movements. I don't know whether you can see the markings here. See, this is something like 130 and this is 150. See, from 130 is gone to 150. Increase. Again from 130 to 150. So increase is by more than 15 beats and it lasts for more than 15 seconds. See, this is 1 minute. So it is lasting more than 15 seconds. So that's why we say it's a reactive non-stress test. There are two movements and there's increased by more than 15 beats twice. That's a reactive NST. Right, let's move on and see the next bit. Okay, what is the frequency of doing this NST? So how frequent do you do the NST for anybody who is pregnant? I said theoretically you can do it after the 28th week, but we generally start doing after the 32 weeks. And then normal pregnancy, you do it once per week. And in a case of high risk pregnancy, we do it twice a week. In a case of diabetes and severe hypertension, but controlled diabetes and severe hypertension, we do it once in 2 days, that is once in 48 hours. We are very strict with these patients for the fear of loss of losing a baby. And then uncontrolled diabetes, we do a daily non-stress test. Yes, so these are the two things which have come in your NEET exams. Right, so let us see the non-reactive NST. What is that? So if there is a NST which is non-reactive, then what is the meaning of that? So when the NST is non-reactive, what is the meaning of that? So let me tell you here. To do the test for longer than 40 minutes to account for the sleep pattern of the baby. That is, you know that the baby is sleeping in the mother's uterus for something like more than 20 hours a day. So you have taken a woman to the OPD, you put a belt on her tummy, and you're seeing the fetal heart rate. The fetal heart rate is fine. Fetal heart rate is at 130. What do you want? There should be a movement and they should be increased by 15 beats, last for 15 seconds. That's what is the definition. But when you're doing this NST, the baby is not moving at all. And the NST is hence called non-reactive. What I told you, reactive NST just now, that is not happening. There is no movement, there is no increase in the heart rate. Does that mean the baby is dead? No, the baby is alive. The heart rate is fine. It is at 130. Does that mean the baby is at any distress? Arey nahi bhai, the heart rate is at 130. He is not under any stress. He is just simply sleeping. If you are sleeping tonight and your heart rate is at 64, you think you are sick? You think you are dead? No. So do not equate a non-reactive NST with a dead baby or a very sick baby. That's the biggest mistake you do. NST which is reactive, we are happy. NST which is non-reactive, we have to do further testing. Non-reactive NST is not always equal to fetal distress. It could be that there is some problem, but it does not mean distress straight away. It could mean a problem, but it does definitely not mean that it is distress. So non-reactive NST is simply many a times because the baby is sleeping. So what we do the test longer, or we give her a meal, and with the meal the baby starts moving. So that's why we always say do it after a meal, so that there is less chance of getting a non-reactive NST. So yes, can repeat after a meal. Even if it is, the baby's heart rate is fine and is not reactive, we can repeat it after a meal. And we can do a stimulation, that I've given a mother food and still the baby is not moving. So I can make a, large barking kind of sound with the instrument. We have an instrument which makes a loud noise. And at the same time, there's a vibrating instrument kept on the mother's abdomen. So it's like, just like, brrr, like that, it startles the baby. That's a stimulus of 1 or 2 seconds, that's all, like that, and a loud noise next to the mother's abdomen. So that startles the baby. Moment the baby gets startled, his heart rate increases. So the baby gets startled and the heart rate increases, fair enough, the baby is fine. So can repeat the NST after a meal if it is non-reactive, can repeat it after a meal, and can do the vibroacoustic stimulation test. So a stimulus of 1 or 2 seconds is given. Now, if it is non-reactive for more than 90 minutes, then we say it's an ominous NST. If it is non-reactive for 90 minutes, we've tried all our stunts. So continuous non-reactive NST can suggest CNS depression. Continuous non-reactive after giving meal also, stimulus also. So next, what you can do a biophysical profile or a contraction stress test. Yes. Next is to step into better tests. I'm not saying that biophysical profile is done only for a non-reactive NST. But yes, one of the managements of a non-reactive NST is to do the next better test to assess if the baby is actually under a problem. It's just that it's a temporary problem of a non-reactive NST. Right. So those are the other tests. So just anyway look at a biophysical profile. What it is a much more advanced test. In the biophysical profile, there are 5 things which are included. The NST is included in this, and then there are 4 parameters on the ultrasound, namely the fetal movements, the fetal breathing, the tone of the baby, and the amniotic fluid index. So there are 4 things which are seen in addition to NST. So it's a combination test of non-stress test, which I told you, and then on the ultrasound, you see the fetal breathing. Basically, it is the swallowing of liquor. So baby, is not breathing inside the mother's uterus. Obviously, he's surrounded by liquor, so he's not breathing. But what he does, he swallows amniotic fluid. So every time he swallows, it's like that, isn't swallowing. So the chest will expand a little. Under the ultrasound, you can see the chest expanding a little. Rhythmic chest expansion. So those, if you see around 3-4 times, then you say that the baby is having a good breathing movement. And then if you see fetal movements, and then you see the fetal tone is good. What is tone? That the baby is in an attitude of flexion. He does a extension of his limbs, any one limb, and then a flexion. So there's one extension with a flexion is a good tone. If you see around 2 in that 30-minute, at least one you see in a 30-minute observation time, then that is what is a good tone of the baby. And then you can also see the amniotic fluid index. So these 4 plus NST is known as a biophysical profile. So all of these are given 2 points each. We give 2 points each to all these 5. So 10 out of 10 is profile, and 8 by 10 is an acceptable biophysical profile, but the AFI should be normal. That is what we always say. The amniotic fluid index, if that is not normal, then we are worried. So the score should be 10 by 10 to be perfect. It is not 10 by 10. Some more categories of this, but at least we'll understand this, that 6 by 10 is lesser is reason for us to think in terms of termination of pregnancy. All right. Some of us, we know that if it is 6 by 10, we are worried, but if the liquor is fine, then we can wait for some time. We can repeat this biophysical profile. But if the liquor is bad and is 6 by 10, then we know it is chronically hypoxic baby. So yes, there are more subdivisions to this, but at least we'll understand so much so far. Then that is the biophysical profile. Now, what is the modified biophysical profile? Now, this is the MCQ question and the exam question for all my MBBS students. Modified biophysical profile is much faster, and it is more much lesser cumbersome. So that is biophysical profile having only NST and A5. If you do just the NST, will take around, we do it till 20 minutes, but sometimes NST is reactive in 10 minutes, and to do amniotic fluid index takes 1 minute or 2 minutes. Basically, by 10-15 minutes, you can do this test, and it is just as reliable. They say almost, not equally reliable, but almost as reliable as the complete biophysical profile. So a lot of us do the modified biophysical profile, and we are assured about the health of the baby. Right. So what is this amniotic fluid index? We've been telling about A5 in the biophysical profile. Now the liquor, the amniotic fluid, the liquor is the fluid of life for the baby. Baby keeps swallowing this liquor. It perfuses the organs. The water volume in the baby will increase, and then the baby has a good renal perfusion, so he'll have a good output also. So the liquor, major contribution to the liquor is the fetal urine, the kidneys. And if that liquor is good enough, that means the baby is having a healthy perfusion in the body because the kidneys are working well. They're getting good perfusion and good output is coming out. So liquor should be adequate. And that liquor, if it is enough, then the baby can move his arms and he can have this good expansion of the chest every time he swallows fluid. So movement of the arms will develop the muscles and the bones. And if the liquor is less, so the uterus will be compressing on the baby and he'll be restricted and he'll be having inturned limbs and flattening of faces, and chest won't expand properly. So there'll be pulmonary hyperplasia, what we've taught you as the problem of primary pulmonary hyperplasia, which can be there because of oligohydramnios. So all of that, remember, Potter's triad, Potter's syndrome, pediatricians also keep teaching you. All of that can happen because of low liquor. So liquor is extremely important. Along with that, the NST is good, then the baby is fine. So yes, amniotic fluid index, it's the mother in a supine position, and you put the ultrasound probe here, 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 and here, 4 quadrants. And with that 4 quadrants, you see the liquor volume. Now the liquor volume is calculated by the vertical depth of 4 pockets on the 4 pockets. Suppose in this example, I'm showing you 3 centimeters, one pocket 2 centimeters, other one 4 centimeters and 3 centimeters. So it is 12 centimeters. Just you simply add it. So 12 centimeters is the AFI in this example, 12 centimeters in this one. As simple as that. It's the arithmetic sum. Now don't take the average of this, don't take the median of this, and don't take the highest value as the index. There's so many, I know I keep listening to a lot of you students and you keep getting confused for no reason. This is the simplest of the test. You do the ultrasound and the 4 vertical depths are just added. That's as simple as that. Okay. So what you should remember, there should not be any umbilical cord in this pocket. Okay, they'll be showing a pseudo high level. It's like if you have 20 ml of water in your glass and you put a lot of rocks in your glass, it will show that it is a higher level. But the rocks is the reason why the level is high. It's not more than 20 ml anyway. It's just that the rocks are showing you the level has gone till the top of the glass. So similarly, there should be a cord free 4 pockets of Leica which are not having umbilical cord. They should be cord free umbilical Leica pockets. So this one, if you see the Leica, I'm trying to show you the vertical depth. See the vertical depth 1, 2, 3 and 4. These 4 depths of Leica 4 pockets are arithmetically added. So now if you see the amniotic fluid index, normal is 10 to 15 centimeters. Beg your pardon, 10 to 15 centimeters. Oligohydramnios is less than 5 centimeters. So in normal amount, we said 10 to 15 centimeters is 1000 ml of Leica, less than 5 is 500 ml lesser of Leica, and polyhydramnios is more than 25. Now more than 25 is not 2500, okay, I have not said 2500, okay, I am saying more than 2000, so not to get confused about that, okay. So this is in the index. What is the normal index? This one, and the volume is here. So either way, they can keep asking in the exams. Now, we'll just tell you what is something called the single pocket criteria. So, single pocket criteria, which is there, that if any one pocket, 4 pockets you have to see, if any one pocket is more than 8 centimeters, it is polyhydramnios, and if it is less than 2 centimeters, we say it is oligohydramnios, irrespective of the value of the other 3 pockets. Even one pocket less than 2 centimeters, we say it is oligohydramnios. Alright, so that is the single pocket criteria. So, more about Leica I have to tell you, but before that, lag, Saurav Chatterjee, Kolkata, yes sir, right, once in 48 hours, yes. I'm so sorry, there's some problem with my display TV, so I should be seeing it there, it'll be easier for me, but anyway, I'm there to see your questions. Don't think that I'm not going to answer them, whatever questions you have, right. So let us see the amniotic fluid with the gestational age. Now this is that graph which all my students, I mean my MBBS students don't know the intensity of this graph, but my PG entrance students and my MCI students, they know this very well, because there's so much of controversy when the Leica is maximum. So let's try and settle this for once and for all. So the maximum amount of Leica is around 32 to 34 weeks of gestation, and it is 1000 m's. Your theory exam is over. Now let me just make the graph. So the Leica keeps progressively increasing till 32 weeks, and till 34 weeks it is 1000 ml. After that it is reducing, and by term it is only around 600 ml. It is reduced by the time the baby goes till term. So the Leica is maximum at 32 to 34 weeks. It's a range. In fact, if you see at 36 weeks, it becomes 800 ml. So that's the time. At 36 weeks, we do something called the external cephalic version in breech, because the Leica is reducing and the baby is bigger. So if you turn the baby, he will stay turned. That's the reason why we do the version also after 34 weeks when the Leica is reducing. So this is actually correct, because it's the basis of my obstetrics. I can do external cephalic version, that is correcting a breech to cephalic, only after 34 weeks, because at 36 weeks the Leica is reducing. That's outright basic obstetrics. So don't tell me that the Leica progressively increases till term. No, it does not progressively increase till term. It increases only till 32 to 34 weeks. So that is the outright basic. Now, controversy is whether it is 32 weeks or 34 weeks. They have never asked you this question in any MCQ exam. No, they've given you one value, and that is 32 weeks, and it has come recently only in the MCI exam, the foreign medical graduate exam, that when is the Leica maximum? 28 weeks, 32 weeks, 36 weeks and 40 weeks. Nobody will give you 32 to 34 weeks. You know, you can trouble a person by giving very close ranges. Like if I ask you what is the length of the female urethra, you know it is around 4 centimeters. Now you can trouble a person by saying it is 3.9, 4, 4.1, 4.2 centimeters. In fact, all 4 are correct, isn't it? So we cannot give you a range which is very close. Similarly, Leica range cannot be so close to pick up one. So 32 to 34 is correct. If they ask you to mark 1, please mark 32 because that's what came in an exam. Okay, let me show you the graph where it will be more better understood. This is kind courtesy the American Journal of Obs and Gynae. This is that landmark paper, and this picture is there all over the internet. If you want, you can see. So look at 32 weeks, this is 36 weeks, and this is 34 weeks. And look at the 50th centile value. And let's see, 32 to 34 weeks. In between that, I'm taking a line like this. See this? See this? 32 to 34 in between that. So 50 weeks maximum is around the 32 to 34 weeks. And 75th centile is there, 95th centile is there, 99th centile. All of these are maximum around the 32 to 34 weeks. So they will not ask you to pick up between 32 to 34. They'll give you one of them, and mostly they'll give you 32. Right? So yeah, this one I expect you to ask me some questions. Are you asking me some questions? You're not. Yeah. Okay. Now let's move on and see some other things. In the antepartum surveillance, we can also check for the perfusion to the baby by the Doppler assessment. So with the Doppler, we see if the the umbilical artery is taking good amount of fluid to the baby, and with the Doppler, we can see of the umbilical artery. We can also see Doppler of the middle cerebral artery. We can see the Doppler of the uterine artery, which is taking good supply to the uterus. So generally, we see the umbilical artery Doppler for the well-being of the baby. So if the perfusion is good, then also Doppler is not done for everybody. Okay, please. Doppler is generally done when we know it's a baby which is compromised. Let's say it's a small baby, IUGR baby. So it is part of the antepartum surveillance, but it is not the primary test. Primary tests are stethoscope and FHS and the fetal movement assessment by the mother, non-stress test. By that, if they are fine, we continue pregnancy. If required, we do the biophysical profile. Okay, so Doppler comes into the next step where we are having proven smaller babies, then we or borderline small babies, and very severe, there is hypertension which is not controlled. Those high risk patients, we do the Doppler. So it's a Doppler of the umbilical artery. It is most common for the fetal well-being. If you want to do this, is the most common Doppler we do, umbilical artery. Then Doppler of the middle cerebral artery, reliable for assessing the fetal anemia. We've discussed that in the chapter of RH isomization, that when there is anemia in the baby, the blood flow to the brain will increase. So middle cerebral artery flow increases in fetal anemia. And then Doppler of the ductus venosus. Now that's a reliable indicator again, because for cardiac dysfunctions, you will see this. The reversal in the ductus venosus flow suggests a fetal death will happen in a week, and absent AVA also will tell us that there is compromise in the fetal perfusion. So what is the the common Doppler which we do? It's the Doppler of the umbilical artery. Let us see the interpretation of that at least. So if you see there is if you see the flow in the flow in you and me also, how much is your blood pressure in your arm, in your brachial artery, how much is the blood pressure? We put the sphygmomanometer and we see it is 120 by 80. So 120 systolic, 80 diastolic. What I'm trying to say, there is perfusion in your arm in systole 120, in diastole 80. There's always perfusion in your arm. Similarly, all over body the blood pressure is 120 by 80, correct? Now, systolic flow is there in your arm and diastolic flow is there in your arm. So similarly, there is systolic flow to the baby and diastolic flow to the baby. Systole, diastole, but systole there will be more flow, obviously you can make out, and diastole there will be lesser flow, right? So that is normal. This picture is of a normal Doppler of the uterine artery. Now, there is systolic flow, and in diastole there is a notching. There is some amount of restriction in the Doppler in the diastole. Systole flow, diastole there is some restriction in the flow. It's not as smooth. So it is the first sign. It is the first sign of compromised flow. First sign of compromise in the flow is this diastolic notching. Diastolic notching is the first sign of compromise. And then if you see there is systolic flow, but there is no diastolic flow, absent diastolic flow. When there is absent diastolic flow, that means there is a severe compromise. A severe compromise means that now you have to deliver. Please deliver. In this, we will deliver in 1 or 2 days. You're not going to wait much long, because this is a case of a severe compromise. maybe today itself we are going to deliver, or maybe do a cesarean. I'm not saying it's an indication for cesarean. It is telling me that there is flow only in a systole and diastole, there is no flow. So yes, mostly they end up in cesareans, yes, but not a definite cesarean. Then there is this flow pattern where there is systolic flow, but there is reversal in the diastolic flow. Now reversal diastolic flow. Now that is not compromised, that is impending or imminent. That is imminent death. The baby is about to die at any given time, because there is flow only in systole. In diastole, some blood is coming out. So there is flow only in the systole. Forget absent diastolic flow, the blood is coming out of the baby in the diastole. So now what is going to happen? Just that any given time the systolic flow is going to stop, and 30 to 40 seconds later the baby is going to die. So this means deliver the baby now, and no normal delivery. This means a cesarean. But yes, you will deliver such babies, compromised babies, definitely they are, by a cesarean to save them. Only if they are beyond 28 weeks. Because even normal babies in our country we can save after 28 weeks. So yes, only if it is more than, if it is more than 28 weeks, then we say I will do a cesarean section. Okay, this is outright basic understanding. There could be many, subtexts to this basic information which I've given you. There will be many other things to be looked at, but for the time being, we should understand the basics of the Doppler. Then, this is the picture of the normal Doppler, systolic, diastolic. This is the absent diastolic flow. This is a reverse diastolic flow. Yes. So, I know if you look at these pictures, it is just same demonstrative of what we discussed just now. So, let's see contraction stress test. Again, the antepartum fetal surveillance. It is part of the surveillance. Now, what is happening? You reach till term. Let's say you reach till 37 weeks, and the baby is a baby of a mother with severe hypertension. The blood pressure is controlled. The mother did not show any convulsion. She's fine. She's had hypertension with, let's say, even proteinuria, preeclampsia she had, not eclampsia, preeclampsia. And you are very good with your BP control, and the baby was fine. Everything was fine, and you reach 37 weeks. And hypertension control on 2 drugs. You have to deliver at 37 weeks. So this baby, when the delivery is happening, excuse me, during the delivery, the baby may have more stress because of the uterine contraction, and with the uterine contraction, who knows, the baby may have a sudden bradycardia and may not make it in labor. So I'm worried about such high risk pregnancies. So yes, I would want to do a normal delivery for all my patients, but I will have to do a cesarean to save lives. So I'm not saying cesarean is the answer to all the problems in obstetrics. No, cesarean is one of the options to many problems in obstetrics. Correct, but not all the options are towards cesarean. Don't think that way. So if I have to do a delivery, I will try to see before labor starts whether this baby can withstand labor. So she's not in labor, she's sitting in the ward, she's 37 weeks and she's waiting for me to take rounds, and she says, sir, kya karna hai bataiye? I'm 37 weeks, you said to wait till, let's say, of 21st of January 2026. Now I'm 37 weeks. How you plan to deliver me? Let me see. I cannot think of putting you into labor and taking the risk. Let me see how you behave in labor. I'll just induce a few contractions. I'll start an oxytocin drip. Okay, keep things ready if at all there's a distress. I'll start an oxytocin drip, and with the oxytocin drip, I'll try to induce a few contractions, and with the contraction, I'll see your fetal heart rate. So I'll put 2 belts on the tummy of the mother. One belt for the fetal heart rate, another belt for the uterine contractions. With the contraction, what happens to the fetal heart rate? That's what I'm going to see. So contraction stress test, induce contractions before the delivery time, and purpose is to evaluate if a baby can tolerate the stress of uterine contractions. So objectives are to assess the fetal well-being, evaluate the placental function. If the perfusion is good, then the baby will tolerate, and identify fetal distress if it happens, and make decisions on the method of delivery. All that I already told you. This for the purpose of you to take your notes, right? So what is the method? It is generally done around 35-36 weeks, and around 35 to 36 weeks after a non-reactive NST or after a abnormal biophysical profile, to see if we can attempt a normal delivery. And it is done for the high-risk pregnancies. And the method is to induce contraction. Oxytocin infusion, we can give oxytocin infusion, or we can do a nipple stimulation test. We'll tell the mother to, roll her nipples with her fingers. She will rub the nipples, and nipple stimulation, is going to cause release of oxytocin, contractions. So we try to achieve at least try to achieve at least 3 contraction in 10 minutes or 40 to 45 seconds. And if late deceleration is seen, in more than 50% of the contraction, that is a compromised fetus. Then you'll have to do a cesarean section as the method of delivery if there are late deceleration seen. So what are late decelerations? I didn't teach you that so far, isn't it? Because that is what is next. So you must understand that contraction stress test is part of the antepartum fetal surveillance, but you inducing labor, you inducing few contractions, I beg your pardon, the right word is inducing a few contractions to see what will happen in labor. So that is a antepartum test to see the probability of doing a normal delivery. So let us see what we can do during the labor, intrapartum fetal surveillance. Before that, what are you guys asking me? Let me go back and see. Video is getting stuck. Okay, contraction stress test. All right. Let me just give a. I've sent a note to the team and they will see. Just give me a moment, guys. I'm just putting the audio off so that you can't hear what I'm talking. Right, guys. So I think we have just another couple of tests. I think we'll see this, and if there's a problem, then we can give you. All of you can see it on a different medium. We'll give you that. But try and understand the most important test in the intrapartum fetal surveillance is the cardiotocography. We're coming to that now. So during labor, we have to do the intrapartum surveillance. So intrapartum surveillance during labor, again the fetal heart rate has to be seen. The fetal heart, same instruments which we have, the stethoscope, we can see the fetal Doppler, and we can use the fetal Doppler, and we can use the Pinard fetoscope again. So the same 3 instruments can be used to see the fetal heart rate during the labor also. Then this is the fetal Doppler, this is the Pinard fetoscope. Then when the cervix is more than 4 to 5 centimeters, we can make a small nick on the fetal head to get 1 or 2 drops of blood. Why am I doing that sometimes? To do the scalp blood pH. Sometimes the fetal heart rate might be fine. By the time the fetal heart rate gets compromised, it will be too late sometimes. So the heart rate is fine, but it's not showing much variability. So when the the baby is a high risk, I mean it's a high risk pregnancy, and I'm worried about that there could be something wrong with the pregnancy. So I want to make sure that there is nothing wrong with the baby. So I can go into the vagina with the instrument, and through the cervix, which is now 4 to 5 centimeters dilated, I can make a nick on the head of the baby and get 1 or 2 drops of blood. And that blood, I can do the pH of the baby while he's inside the mother's uterus. That is what is known as a fetal scalp blood pH. That is also part of the intrapartum surveillance. So yes, scalp blood pH, and that pH is checked, and if it is less than 7.2, then we say it is acidosis, and that is indication for a cesarean section. Scalp blood pH less than 7.2. So if you see this uterus with the head of the baby, and now I've got this conical instrument. With this I go inside, and I have got a sharp instrument which goes through this and makes a nick on the head of the baby, and we get out some blood. and that we can see the pH. So we can get the estimation of the fetus while the baby is still inside the uterus, the fetal scalp blood pH, right? Okay, I think I can. Yeah, there is somewhere it is getting stuck. I know I could make out that also myself. Mm-hmm. Okay, about the cardiotocography. The cardiotocography is like this, that if you see the cardiotocography, it is the next big test for the assessment. So, I told you about the intrapartum fetal surveillance, we can do by the assessment of the fetal heart rate. After the assessment of the fetal heart rate, we see the fetal scalp blood pH. There are things we can do apart from this also, that we can do the fetal ECG. You can put two probes on the head of the baby and check the ECG of the fetus. But there is the very important fetal surveillance test known as the cardiotocography. Cardiotocography. So, what is cardiotocography? It is the assessment of the fetal heart rate. Cardiotocography. We have the belt to check. We have the belt to check the fetal heart rate by one probe, and we have another belt to check the uterine contractions. One is to check the fetal heart rate. With the uterine contraction, what happens to the fetal heart rate? So, with the uterine contraction, what happens to the fetal heart rate? I am trying to show you. Suppose the fetal heart rate is at 150. Now, with the uterine contraction, with the peak of the uterine contraction, you see the lowest fetal heart rate. This is known as the nadir also, lowest fetal heart rate, also known as the nadir. So, with the peak of the contraction, you see the lowest fetal heart rate. That is what is known as the early deceleration. This is known as the early deceleration. Uterus contracts, heart rate goes low. This is, the uterus is contracting on the fetal head. So, when the fetal head gets compressed, there will be vagal stimulation that reduces the fetal heart rate. So, it is known as the early deceleration or known as the type 1 deceleration. Early deceleration or type 1 deceleration, where the peak is coinciding with the lowest heart rate. Look here, this is not again distress. We are talking about deceleration. It is not distress. So, fetal heart is 150, it comes down to, let's say, 130. It is 150, it comes down to, let's say, 130. So, this is what is the reduction in the fetal heart rate. It is not distress again. So, early deceleration or type 1 deceleration, it is seen in head compression. It is seen in head compression, and it is a normal in active stage of labor, which is after equal to only the deceleration is happening. So, basically what is happening, the uterus has contracted, the placenta has emptied. When the placenta empties, the heart rate will go down a little, not distress again. This is not distress again. Please don't get confused. It is 150 here, it has gone to 130 here. Uterus contracts, placenta empties. Uterus relaxes, placenta refills. That's what happens normally. But now the uterus is contracted, but the placenta is having calcific blood vessels or narrow blood vessels because of, let's say, preeclampsia or IUGR. So, the uterus contracts, the placenta empties slowly. Uterus relaxes, placenta refills slowly. So, that is what is a delay in the heart rate going down and a delay in a heart rate picking up. That is what is known as a late deceleration. It is basically placental insufficiency. So, please understand, contraction does not coincide with the lowest heart rate. It is seen in placental insufficiency. All right, and it is also called the late deceleration. It is also called the type 2 deceleration, and this is not normal. We are not happy with this one. This is not normal. So, you see this is the uterine contraction. This graph of one of my patients here. So this is late. See, peak of contraction, the lowest heart rate. There's some disconnect here. So see this. This is what is a late deceleration. All right. So this is not normal. Look again. It is not distress. It is deceleration. That's why we are discussing. Anytime it is more than 110 and less than more than 160 and less than 110, we say it is distress. So that we are not talking. We are talking about between 120 to 160, the heart rate goes up, it is acceleration, goes down, it is deceleration. We are talking only about that. So if it is just coming down, see, it has come down to around 110. This is around 110. So this is not distress. Less than 110 is distress. So this is what is late deceleration. Now the uterus contracts and the heart rate is basically going low whenever it wants to go low, and it doesn't follow any particular pattern. So there is no particular relation with the contraction. So this deceleration of the heart can happen even without a contraction. So what is that cause of a deceleration happening without any contraction happening? That is because the umbilical cord gets compressed. It may get turned around the arm or around the leg of the baby. It may get tied around the neck of the baby. It may get compressed in so many places. It can get compressed between the uterine wall and the body of the baby. It can get compressed many times. So cord compression can cause these variable, some deceleration, more deceleration, then much lesser, then much higher, variable deceleration. All right. So this variable deceleration, okay, this got nothing to do. This variable deceleration, nothing to do with uterine contraction. Variable deceleration. Right. It is no connection with the uterine action. It is seen in umbilical cord. It is seen in the umbilical cord compression. And most common type of deceleration, and it is mostly safe. Don't say that it is always safe. Look, the safest deceleration, I've already given you the answer. It is the head compression causing the early deceleration. What is not normal is the late deceleration. Now, this is mostly safe, but this is the most common type of deceleration. It can be seen in low liquor, such as in premature rupture of membranes. And if the liquor is low, the uterus might, compress on the cord more, and the presenting part may compress on the cord on the side. So it may be getting compressed around the arm. So when the liquor is less, compressions are more likely to happen, right? So this is not supposed to be ominous. Most of the times it is a self-limiting thing. It gets corrected by changing the position or by giving some oxygen to the mother. Mostly we are not worried about this variable deceleration. It can happen, but if they're persisting for a long time, then it is ominous. That's what I'm telling you here. If it is brief, less than 30 seconds and non-repetitive, then does not indicate these variable decelerations. I'm talking again, variable decelerations. If they are brief, less than 30 seconds and non-repetitive, then does not indicate fetal distress. And then if it is repetitive and having persistence, it is repetitive variable deceleration, it is persisting for more than 2 minutes sometimes. So that has a worse fetal prognosis, greater risk of C-section due to fetal distress. If they are repetitive and they are persisting, then we say they are a little bit, they are not little bit, then they can be suggesting that the baby is having distress. All right. So this is what I wanted to. We can get back to you guys at some other time with the questions on this. You can always, send me questions on the chat of this, and we can always talk about this. So I'm still waiting for you. I'm still waiting for you to tell me if there is, if there are any questions. You can tell me. I'll type to you. I think you're not getting it properly. Last part of the graph. This one. This is the variable deceleration. Who is asking me? Sutta Prasmanta. Yes. Sutta, this one, this is the part where you have to understand the last graph, that with the uterine contraction, there is no particular variability in the heart rate. The heart rate is not getting reduced by head compression or placental insufficiency. None of these are happening. It is because the cord is getting compressed. So, cord can get compressed even without a contraction. So, if that is happening, that is why it has got no relation. See, it has got no connection with the uterine action, and that is why it is called a variable deceleration. Now, variable deceleration is because the cord is getting compressed and the cord gets relaxed, the heart rate recovers. So, mostly this is normal. It is mostly normal. I am not saying always normal. There are more variations to this, and with a bad transmission, I don't want to get into all of those things right now. They're generally not coming in most of the exams. They've not come in even in the PG entrance exams, or for the PGs also we don't trouble them so much. So I'll hold down for all those. But if we are having a lot of delays somehow. I'm apologies for this. Okay, I think. You'll see it eventually. I think I'll take a leave. Will take your leave for now. We'll get back tomorrow. Okay, guys? Chalo. Thanks so much for your time, and apologies for the. I don't know why this error is happening. Maybe there is some problem with the transmission. My internet is working absolutely fine here. I can see everything moving in my studio. So there must be some errors. We'll probably correct them by tomorrow. Thank you, guys. And whatever questions you have, this is a very important chapter. Please rewind and see this. Okay. Thank you so much.